All right. So I'm so excited, you guys. Today we have Dr. Marcus Maurer. He is professor of dermatology and allergy, head of specialty clinics for Urticaria. He has a lot of knowledge to share with us. So I'm super excited. Thank you so much, Dr. Maurer, for coming on with us today.
My pleasure. I'm very happy to do this again.
Yeah, I appreciate it. We have a lot of questions from our group. And I have a question for you. I'm curious. You seem so passionate about it. Have you experienced chronic urticaria yourself?
Acute urticaria. Actually, that was one of the reasons why when my daughter asked me if I wanted to do some TikTok work with her, I said yes, because I know how frightening it can be to have urticaria and to not know. This was long before I worked on urticaria. Yeah, no, my daughter had it, my son had it, I had it. So I know from personal experience that yeah, it can be really frightening to have these wheals. And one of us also had angioedema, so
Oh yeah.
nice. Yeah.
Yeah, that's definitely frightening for people. Okay, so that explains why because I feel like a lot of doctors don't truly understand how it can impact your life if you're going through this day in, day out.
It is, and it's a kind of a surprise because we've all been bitten by mosquitoes. We've all touched stinging nettles, at least in my country. Many of us have had contact with these jellyfish, no, but we tend to forget. No one likes to remember pain and itch. It's just something. But when you have it, next time you have a mosquito bite, just think about how dominant this is. This is all you can think about. And patients with urticaria, they know very well that, well, hundreds of them every day or almost every day, this is what they have to live with. So it is difficult, I think, for physicians sometimes to put themselves into the shoes of their patients, and all the more important to listen to patients when they talk about what this does to their lives. Not just the itch, no, that's part of it, but also the sleep and the food and the not knowing when it will happen and not being able to travel. And, you know, there's so many things that are ruined by this stupid disease. It just makes sense for us as treating physicians to listen a bit more to what patients tell us about how bad this disease is.
Yeah, it really can take over your life. And it's so refreshing to hear someone like yourself, say things like that, just acknowledge that for us. So as far as when someone first goes to their doctor, with these symptoms, we talked last time about, bringing pictures and things like that so you can advocate for yourself. But what kind of testing should we be looking for our doctors to, go through before we're diagnosed with idiopathic or spontaneous urticaria?
Look, this is really something that you don't need any tests for. This is your eyes and maybe your fingers and maybe your phone. No, this is what we need to diagnose it, and the right questions, of course. I don't need a blood test. I don't need imaging. I don't need an X-ray. All I need is to listen to patients tell me what happened, and for them to describe what their skin looked like and for how long they've had it and whether or not these wheals come by themselves or patients can make them come. And then to look at the picture. And if it matches up, I know that I have urticaria. If it's longer than 6 weeks, I know it is chronic. And when they come unpredictably, I know it is spontaneous. That's how easy it is. So, Sarah, tell you the truth, I don't really know why so many patients have such a hard time to get the correct diagnosis. Why so many patients apparently get diagnosed with something else when it is actually not that difficult to say this is chronic urticaria and this is chronic spontaneous urticaria and this is chronic inducible urticaria. I mean, what follows then, no, that's where some of the tests can make sense depending on what answers you give to my questions, but not to diagnose what you have.
Right. Okay. So a lot of doctors do like a punch biopsy. Is that necessary?
No.
Okay.
Look, the punch biopsy is not a big deal, of course, no, but it does leave a hole, and no one likes to have holes when it's not necessary in their skin.
Right.
The punch biopsies can be interesting when there is doubt whether this is chronic spontaneous urticaria, because there is one disease, actually there's a couple of diseases, they're super rare, but a group of diseases that can look like chronic spontaneous urticaria, Urticaria Vasculitis, for example, or autoinflammatory syndromes. Patients have wheals very similar or identical to the wheals that patients with chronic spontaneous urticaria have. But when you take a biopsy, when you do that punch biopsy and you look at it under the microscope, you see that this is more than mast cell degranulation, which is the hallmark feature of chronic spontaneous urticaria, and you see signs of vasculitis, and that helps us then to move forward and establish the correct diagnosis. But in 99 out of 100 cases of chronic spontaneous urticaria, I don't need a biopsy. And that does not mean that I want skin of urticaria patients. Why? Because we need to learn about this disease. So for scientific purposes, my goodness, it makes a lot of sense to look a bit closer. But to establish the diagnosis, it is usually not needed.
Okay, gotcha. So after diagnosis, is there further testing, say like thyroid, H. pylori, those kinds of things?
Good question. So when we discussed the last update of the guideline, we said, well, it makes sense to look at markers of inflammations, just so we don't overlook anything. And the one biomarker that we look at for inflammation is called CRP. C-reactive protein. You don't need to know this, but just if you see that on your notes, then that was done to see if you have a marker of systemic inflammation. The other one is a differential, just to get some idea that there's not something really wrong. It's more to get our bearings. Now, the two new ones that are in the guideline are interesting. Why? The first one is IgE. IgE is what we all have, what allergic patients have against what they are allergic to, and what patients with chronic spontaneous urticaria either have very little of, and that's a sign of autoimmune chronic spontaneous urticaria, or they have normal or high levels, which can point to autoallergic chronic spontaneous urticaria. So it's actually one of my favorite markers, not that it makes me do things differently, but I have a different expectation. When I take your blood and I see, ooh, your IgE is 8, and it should be 30, 40, 50. And I go, oh, this could be a sign of autoimmune chronic spontaneous urticaria, the hard to treat one. And then I dig deeper. Then I may be doing more tests, may ask more questions. So it guides my diagnostic approach. And the other one you already mentioned, looking at the thyroid, which is the easiest way to do this is to look at thyroid autoantibodies. Has your body started to make an autoimmune response to your own thyroid? This is very much linked to autoimmune chronic spontaneous urticaria. So if I have a low IgE plus elevated levels of IgG anti-TPO, that's the thyroid autoantibody, well, that's a big pointer towards autoimmune urticaria. And then I know that I have to probably step up my game a bit more than if you had high IgE levels and normal thyroid autoantibodies.
Okay, that's really interesting, because that was going to be one of my questions. If allergy or the autoallergy versus autoimmune, is the treatment different? How do those look different? Does it matter?
It does matter, Sarah. Then that doesn't mean that we do things differently. If I diagnose you with autoimmune chronic spontaneous urticaria, you will get the same treatment as if I diagnose you with autoallergic urticaria. But I will tell you different things as I recommend that treatment. I will tell you that autoallergy, that's good. You're allergic to yourself. Okay, sounds stupid, is a bit weird, but that is the type of urticaria that we can treat really well with antihistamine, higher than standard dose antihistamine, and if need be with omalizumab. Omalizumab, an anti-IgE, works really well in autoallergic chronic spontaneous urticaria. Now, if you have autoimmune chronic spontaneous urticaria, low IgE, autoantibodies to your thyroid, a positive basophil test, another autoimmune disease, high disease activity. All these pointers to autoimmune chronic spontaneous urticaria. I will still give you an antihistamine, and I will still recommend that you go up in the dose when this 1 tablet per day doesn't work. And if that doesn't work, I will tell you that omalizumab is the anti-IgE is the best thing that you can do. But I will also tell you that it can take time. It can take time, and you may need higher than standard doses of the anti-IgE to experience the same response that someone with autoallergic chronic spontaneous urticaria has with a standard dose. That's the difference. It makes me smarter, and therefore I can give you better advice on what to expect, what will happen, how fast it will happen, and what we may need to do in case it doesn't work with our first try.
Right. Okay. That sounds good. It's good information to have, because I know we have a lot of people who have tried, all the antihistamines. They've tried even the Xolair, and they're not making progress. They seem to not be responding to the Xolair. So are you saying that it takes longer for the Xolair to work and they might need more?
Exactly. I was going to jump right in because you touched on two of the most common mistakes. One antihistamine doesn't work. Well, let's try a second one. Oh, it didn't work. Let's try a third one. That will not bring you to complete response of your disease, which is what we want for you. If an antihistamine doesn't work, the best thing and the only thing one should do is to use a higher dose, double the dose, quadruple the dose, take 4 tablets instead of 1. And quite frankly, in practice, at least in my country, that's where we stall. That's where sometimes patients, sometimes physicians, they say, oh, I don't know, should I really double the dose? It says I should only take 1 per day. And what if I do this for many months or years? Do it. These are safe drugs. You can take them for a long time. And if they do the job, that's the best thing you can do. And here comes the second problem. Now, if we decide, and we should decide that a lot more often than we do, to move to anti-IgE, then we have to give it a chance to work. And that means we shouldn't stop short after 1 dose or 3 doses. We should go for at least half a year.
Okay.
And in that half a year, we should also, if the first 3 months don't really go so well, think about increasing the dose, shortening the interval, giving it every 2 weeks instead of every 4 weeks, or doing both. Give that drug a choice, because what do you have when it doesn't work? You move to cyclosporin or immunosuppressant or back to the old cortisone. No one wants that. Those are not fun drugs to work with. Yes, they may have to be what we use, but not before we maxed out on what antihistamines and anti-IgE can give us.
Okay, that's really good too, because that was going to be another question of mine was, when is it appropriate to use steroids and those immunosuppressants?
Sarah, I haven't used steroids, I don't know, not this year and not last year. And I see a lot of patients with chronic, and maybe you have guessed it, I tend to see the ones that have a lot of problems and have not had good responses to other treatments. There is a way for every patient, and we will not give up. No patient left behind. That's how we work, and we do it without broad immunosuppression. Why? Because we know this is a disease that can last 5 years, 7 years, 10 years, and no one wants to or should be taking corticosteroid, cortisone, for that long, not even for a couple of weeks. It is not needed. So let's stay away from those, and let's move to modern treatment. And you've seen in the guideline, we have anti-IgE. Today, when anti-IgE does not work, I move to off-label treatment with other biologics like dupilumab, which is an anti-IL-4/13, or secukinumab, it's an anti-IL-17. They all have that MAP at the end, which means they're biologics, they're targeted treatment. It's not like cortisone where you bring down the entire immune system. No, you go to a specific part of what drives the disease, and you take that out, and thereby have very few side effects, if any.
Okay, well, that sounds good. Yeah, because I know that that's a big issue too, is the side effects from these medications that people are on, and concerns about taking them long term.
Yeah.
So I wanted to ask you too, with the antihistamines, are there any special considerations for like the older population? Or is it safe to still take those high amounts?
Safe to take those high amounts if you take the right antihistamine. Look, you are in the United States of America, where when I visit, I'm still surprised about the antihistamines I see in supermarkets.
Yeah.
Old sedating antihistamines that no one in Europe uses anymore. Please don't use these old sedating antihistamines. Not in kids, not in anyone. We don't need them. No, as long as you work with the modern, not tired-making antihistamines, you're fine. And you can double the dose and quadruple the dose if you have to. Now, more than 4 tablets per day, you're not going to see that you will get a response with 5 or 6 or 7 when 4 do not work. So that's where we stop. No, we try the doubling, we try the 4 times per day with the modern non-tired making ones, and those are good for all populations of patients, including the young ones and the old ones.
Okay, that's good to know. Another question I had was, what is it? I know last time we talked about how some of us experience more systemic symptoms, like the brain fog and stomach issues, joint pain, that kind of thing. How is that different than like a mast cell activation syndrome?
Okay. Well, mast cell activation syndrome, by definition, is more than one organ affected by mast cell activation. So you could think of chronic spontaneous urticaria as mast cell activation syndrome of one organ. No, the skin is affected by mast cell activation, and it can be that in patients who only have gut signs and symptoms, then that's also mast cell activation or the lung. Now, mast cell activation syndrome per se requires that you have skin symptoms, for example, and symptoms at another organ. So by definition, if you have chronic spontaneous urticaria and you have brain fog, or you have diarrhea, or you have joint ache, pain, that could be considered mast cell activation. We don't do that because you have chronic spontaneous urticaria with systemic signs and symptoms. And for chronic spontaneous urticaria, guess what? I have a guideline, I have licensed treatments, I have patient-reported outcome measures. I can do a lot. Whereas in MCAS, mast cell activation syndrome, I do not have licensed treatment. So it's better to work with a diagnosis, chronic spontaneous urticaria plus systemic signs and symptoms, than to go to mast cell activation syndrome, where we do not understand what's going on really well. We do not have drugs. We do not have ways to measure the disease, including the response to treatment.
Okay, so it sounds like there's less information, less research been done on mast cell activation syndrome.
A lot less is done. It's a disease that we've only really started to understand exists over the last couple of years, let alone understand why it comes into existence. We know it has something to do with mast cells. Obviously, it's in the name. But why these mast cells get activated and why in some patients this activation results in one set of signs and symptoms versus in other patients it's other signs and symptoms, we really don't know. We need a lot more research in mast cell activation syndrome. That is not to say that we don't need more research in urticaria. The two, they complement each other, but it's really two different set of diseases and probably also underlying mechanisms. No, in chronic spontaneous urticaria, we know of autoimmunity, we know of autoallergy, we know of molecules and receptors and cells that are behind the wheel. In MCAS, we really don't know much yet why these mast cells get activated.
Okay, that's interesting. And then what about people who do experience anaphylaxis? Because I know you said that's very rare, but the ones who do experience anaphylaxis, should they take a different route? Should they seek further testing?
Yes. Anaphylaxis is not part of chronic spontaneous urticaria. The two don't go together. You don't have anaphylaxis because of chronic spontaneous urticaria. You do not need an EpiPen with chronic spontaneous urticaria. Now, you can have two things. You can be allergic to peanut and have experienced anaphylaxis, and you can have chronic spontaneous urticaria. The two are not uncommon. So pure statistics, there will be people who have both, but not one because of the other. That's important. Let's Not underestimate chronic urticaria for the impact that it has on patients. It's a horrible disease. I'll sign anywhere you want me to. This is
Thank
a
you.
really stupid and horrible disease, but it is not deadly. It doesn't
Right.
produce anaphylaxis. It doesn't produce angioedema that results in suffocation. When this happens in someone, we need to look for other explanations than chronic urticaria.
Okay. Okay. And then you had mentioned before, like with the punch biopsies and things, like there's different types of urticaria, like you might have neutrophilic or the vascular. Are those treatments going to be different?
Yes. If
Okay.
I do a biopsy to rule out or to verify Urticaria vasculitis, I am going to treat differently if it turns out to be vasculitis. It's a bit unfortunate that it has the name Urticaria in the name of the disease, Urticaria vasculitis. I understand why, because it can look like, it does look like urticaria. No? It has the wheals just like in chronic spontaneous urticaria. But you have to think of the second part of the name of the disease as the important one, vasculitis. That means it's an inflammation of the blood vessels, very different from what happens in urticaria. In urticaria, blood vessels are also involved. No, they get turn to be wide, and that means more blood flows through the skin, but that's not inflammation of the blood vessels. And they become leaky. They become leaky for a couple of minutes to a couple of hours, and what's inside the blood vessel goes into the skin, and that's the wheal, that's the angioedema, but it's not vasculitis in the sense that you have inflammation of the blood vessels, which is the problem with Urticaria vasculitis. So I am going to treat your vasculitis to reduce the urticaria signs and symptoms that you have. Very different diseases, really. And I need to know, is it one or the other? And I will use one treatment or another treatment.
Okay. Okay. As far as like angioedema, why do you know why some people get angioedema and then others don't? Is that the difference between autoimmune and autoallergy? Is there no rhyme or reason?
You saved the hard questions for me this time, Tara. No, I do not know. I wish I do. We debate this quite a bit as urticariologists, and some of us think we know why some patients, in addition to the wheals, have angioedema, why there's some patients who exclusively have angioedema, never have wheals.
Mm-hmm.
But to be honest, we do not know. What we do know is that in both cases, wheal and angioedema, it is skin mast cells. When the wheal is made by mast cells, it's the mast cells that are right beneath the most superficial level of the skin. That's why you you see the wheal. With the angioedema, it's the mast cells deep in the skin that get activated, and that's why you get a bigger lesion, if you want, a bigger swelling. Deeper swelling. But why it sometimes is the superficial mast cells that do something, and in other times it's the deep skin mast cells that get activated, and in many patients both, they have wheals and angioedema. We do not know yet. Current research is looking at this. Why? Because we have angioedema linked to urticaria. That's probably also the most common reason to have these recurrent angioedema. But there are other forms of angioedema that come from very different underlying causes. So we need to establish for routine clinical practice, not for the specialized centers, but for routine clinical practice, for family doctors, for general practitioners, a way to distinguish the different forms of angioedema so that we can give good advice and good treatment to patients with all different types of angioedema.
Right. Okay, so for those of us who might have a doctor who's not real familiar with urticaria and they're kind of brush us off as maybe you're just too stressed, that kind of thing, is there some place that we can point them where they can get information that's not coming from us like, oh, I just did a Google search? Because I know how doctors feel about that.
I used to say, I changed my mind. I changed my mind, and I now think that it does make a lot of sense to look for good information on the internet. And that's in part because now we do have good information on the internet. Look, you're doing a great job. There's other groups that really spread good knowledge. The UCare network, the Urticaria Centers of Reference and Excellence Network. There's patient organization and groups that are now really outside of the clinical setting, provide patients with good information. And good information is so important for patients with urticaria. Sarah, I was going to say you have no idea, but you probably more than many other people have a good idea of what is going on in the heads of patients with urticaria. Mm-hmm. They hear not always helpful information, and they come to a concept of their disease that has them see this as an allergy or as punishment for something they do, or as a psychosomatic disease. All nonsense, all nonsense. And many patients don't really have a concept. They say, I don't know why I have this. My physician doesn't know why I have it. And that's not good. That's really not good. No matter what disease you have, especially with the chronic ones, you need a concept. You need to understand what you're up against. You need to have a way of tackling this problem. But if you can't give it a name, if you can't give it rhyme and reason, then this is going to be very difficult. And you're going to be a victim rather than someone who can master this disease, get it under control. And this is why I think it is very important for physicians not only to provide medication, not only to provide advice on what to do and what not to do, but most of all, to provide information. Why do people get urticaria? What do they have to expect? How long will this last? This is so essential for patients to know and to learn that I can stress this enough. Go figure out credible sources of urticaria information. More and more are coming on board on the internet, offline. If you run into a physician who doesn't know urticaria, be patient and try to bring information to the setting. And if it doesn't work, go find another doctor. There are urticariologists out there, urticariologists who will be happy to see you, knowledgeable, who can help. And there's more and more of us getting organized in global networks so that you can find someone, hopefully, no matter where you live, who is close and can help you.
Yeah, that's so good to hear, because I know I've had it for over 10 years. And when I first started looking, there's very little information, and a lot of it seemed to be incorrect. It was more comparing it to acute urticaria.
Yeah.
So, and when I went to my doctor, it was that, well, it's psychosomatic, and kind of brushed me off, didn't treat any of my symptoms. And it was really very depressing. I was distraught. It was really, really hard to hear. And I started to question myself, like, is this in my head? Am I creating this somehow? So it's so good to hear that, be validated that it's not in my head, it's something happening to my mast cells, and it's not anything I have control over.
When I talk to my colleagues, especially the non-specialists who see a lot more urticaria patients than specialists, actually, because that's the first point of contact that any urticaria patients will seek. I tell them, we know so much. You actually know so much about this disease. Why do you choose to talk about the things we do not know? Yes, there are some things we do not know, no? And you put your finger right where I don't know, no? And I know a lot about urticaria. The angioedema is an area where we're still struggling. MCAS is an area where we're still struggling, and the overlap. But on the other hand, we do know a lot. We know that mast cells are key. We know what comes out of mast cells that makes urticaria patients itchy, makes them have the wheals, make them have the angioedema. We know how long urticaria lasts. We know that there are certain things that many urticaria patients should not do, like take aspirin, ibuprofen, diclofenac, non-steroidal antiphlogistics. We know that stress can be bad in some patients, but not in all. So why don't we talk to patients about what we know and give them helpful advice, rather than discourage and say, we don't know what this is, you just have to live with it, or maybe even it's in your head. It's not in your head. Of course, it goes to your head.
Yeah.
Mamma mia, of course it goes to your head to have wheals every day, and then to have maybe ill-advised management recommendations. of course it goes to your head, and that's part of the problem, and that's what we have to talk about. No, it doesn't make sense for me to say we're doing a great job, everything is fine. No, we're not. We're not making proper use of the medication we have. We're not really good in our communication with patients. We also have to learn a lot about how to best provide good care for patients with chronic urticaria.
Yeah, well, it's really good to know that you're out there, and there's so many out there now doing the research and doing the work and making progress. So that just, I mean, that alone, just you talking to us today just means so much to us.
Well, my pleasure. And you know what? Many of us learn most of what we know from you. Let's not forget that, no? Because 10 years ago, 15 years ago, this was a disease that we didn't understand well. There was no urticariology. No, there was no big textbook that explained it all, and we just didn't read it. No, we had to ask, we had to learn, we had to work with you. And this is why we are a lot further along than we are 5 years ago. Today, if you come to me at my center here in Berlin, we just got a beautiful new center here in the Paul-Ehrlich House. I can offer 8 clinical trials to you to participate in.
Wow.
10 years ago, a big fat 0. There were no clinical trials. There was nothing that was even remotely close to becoming a drug. No, then came omalizumab. Now we have 8 clinical trials, 8 different treatments, some of them very powerful for chronic urticaria under development. So that's something that completely changes the approach. In 5 years, you will have many different treatment options to choose from. 10 years, let's give it 10 years, but 5 years, there will already be some more to make you feel better, make us also look better. No, if you have knowledge of a disease, but nothing to help your patients to treat it with, that's also a bit frustrating for the physician at the other end of the table. But now we do have something that works, and we'll be getting even better treatment options. So the future is bright for urticaria patients and for urticaria treaters.
That's really good to hear. So back to more like the triggering events, things like that. You did mention like stress and those NSAID medications. Are there certain things that we should be trying to manage better, or avoiding certain things?
Well, there's 2 things you ought to know. No, some patients, but not all patients, experience that their disease gets worse with different things. No, that's important. So there is no urticaria diet that helps everyone. There is no, but some patients do see that stress makes it worse. Some patients do see that certain medication makes it worse. Some patients do see that having upper respiratory viral infections make it worse. Now, not all of these things can be avoided. No, not all of these things can be identified. But when you see that there are things that make your urticaria worse and it can be avoided, well, let's try to avoid it. No, I wish I could prescribe a stress-free life to all of my patients who tell me when I see those deadlines or when I am stressed, the disease is worse. Not possible, not easy, but to know that this is not in your head, that you're not imagining that. No, so I actually just last week I had a young woman, still high schooler, and she said, you know, I have this, and every time we have exams, especially math exams, it's really, really bad. You know, and I said, this is not math urticaria, but you are stressed when you have to do math, and stress is a trigger for you. So let's see what we can do about this. So just for her to hear that this is not something that she's imagining, but something that is also experienced by others is important. Let me talk about the stress a little, because, you know, stress is so, what's the English word? It's so abstract. No, what is stress? No, there's good stress and bad stress, but stress is biology. It translates into things, proteins that come into play in our skin when we are stressed. If you want, I can stress you in a controlled setting, and I can look in your skin, measure something in your skin that reflects that level of stress. And guess what? Those proteins that come into your skin when you are stressed are great mast cell activators, many of them. No, they're called substance P and whatnot. No, and we recently, well, the community recently identified a receptor. In other words, a way for mast cells to recognize substance P. It's called mast-related G protein coupled receptor X2. You don't need to remember, we call it X2 because it's such a mouthful. But this receptor is on skin mast cells, and it binds a lot of different signal. And when it does that, it gets activated and translates this activation into the activation of mast cells. So now we can explain that if you are stressed, no, when you are stressed, there is something that comes into your skin, goes to your mast cells, and activates your mast cell. We didn't know this 10 years ago, but now we know. And we're finding all these mechanisms that explain medication-induced worsening, food-induced worsening, virus-induced worsening of chronic urticaria. So my bottom line is, take a diary or use our new app, Cruise, the chronic urticaria self-evaluation app. We launched in Germany. Yeah, we launched last week, and it's coming to other countries as well.
I love that.
Yeah, it's cool. And it allows you to track what's good and bad for you. Also allows you to track your response to treatment. And if you see that something has an impact on your urticaria, well, let's try to work with it. If you don't see it, don't be frustrated. Many patients don't see something that makes it worse or better. That's just the way it is. Good medication this way or with exacerbation is always something that provides protection. And in the end, if you ask me, what do I want to achieve in the life of my patients? It's complete control. And that means that you can even take a math exam and be stressed and still do not experience wheals or angioedema.
Right. Yeah, that would be great. So we have all these different triggers and things, and as you said, everyone's kind of different. Some people don't really have any specific triggers. So it sounds like it's really just a matter of getting to know yourself and keeping that diary and looking for patterns, that kind of thing.
Yeah. And don't overdo it. Now, if you hear on the internet, there's a urticaria diet that you have to try for 6 months, forget it. It doesn't exist. It doesn't make sense. If you see by watching yourself that there are certain foods that make it worse, good. Okay. That gives you an angle to work with. If you don't see them, don't be frustrated. Most patients don't see it as well, see it either. No, it's just something that can help you to get a little bit more of a way to deal with your disease. But the bottom line is you need good information, you need good treatment, and you need a way to measure that the treatment and what you do bring the control to you that you need.
Right. So don't stress yourself out over it. But if you notice that certain foods, like high histamine foods or tomatoes or whatever, making you break out, don't discount it either.
Exactly. Well
okay.
said.
That's good information, because I think some doctors too will say, well, you can eat whatever you want, even though the patient's saying, well, I noticed that this food, I have hives. And they're like, well, that's no.
Yeah.
So that gets a little confusing too. So there's no, you wouldn't say, oh, well, you should try this certain diet or try to eliminate these certain foods, just watching yourself.
Exactly. Just watch yourself. And, I can't overestimate the power of documentation. We all think we remember everything, but we don't. We forget, no? And if we have, after eating sauerkraut, which usually we don't eat every day, more wheals, and 2 weeks later we eat sauerkraut again, we may have forgotten that the last time sauerkraut. It's not sauerkraut all the time. It could be a donut, it could be anything. No? But we forget, no? And sometimes two things have to come together. Maybe you walked the dog and it was a bit warm outside and you had a certain food, and the combination of these two had you have more wheals on that day. Well, just watch yourself and put it into a diary calendar type of documentation and do that for a couple of weeks. How much work is it? It's not a lot of work, and it can help. Don't, as you said, don't put your whole money on it. No, it is very likely that you will not detect anything. But if you do, great. So that's how you keep a good good balance between overdoing it in terms of investigative detective work, but not, on the other hand, losing the opportunity of avoiding things that are easy to avoid and can actually make your life better without the need to increase your medication, for example.
Right. Yeah. And I think that's important too. I think it gives people a sense of there's something that I can control, and it, something that helps me feel like I'm making a difference in my quality of life with the medications, not with that, well, I'm not going to take my medications, but, knowing that medications sometimes are necessary and taking those along with whatever you can do on your own.
Exactly. And look, I don't want you to take more medication than you need. I want to treat your disease until it is gone, until you have no more signs and symptoms. That's actually what we say in the guideline: treat the disease until it is gone. But we also say with as much as needed and as little as possible, in that order. In other words, I will advise you to get that thing under control, but then I will advise you to do it with as little as possible. And what that means is you have a lot of say in this, because only you know how many wheals you have per day, how many angioedema you have. And really, you only know when you document it, when you document it with one of the scores that are so easy now, and even easier with the app now. So it is important that patients do take control and document and keep track and use what they have, the information and the power, to help control their own disease.
I like that. So as far as like when the mast cells are degranulating, so they're releasing more than just histamine, right?
Oh yeah. Oh yeah. Yeah. These
what
are
do we know about these other things that are going on?
They're wonderful cells. If you don't have urticaria, they're really wonderful, wonderful cells. And part of why they're so wonderful is they have more things inside of them stored, ready to be released when they get activated, than any other cell of your human body. They're really quite special, powerful. And these other things that they have, in addition to histamine, many of these other things are also pro-inflammatory. What does that mean? When they get outside from the mast cell into the skin, into the surrounding of the mast cells, they will annoy the blood vessels. They will annoy the sensory nerves and make you itchy. They have inflammation-producing properties. And we are close to 100 things that are inside of a single mast cell. Histamine is one of them. So you can imagine the cocktail of inflammation makers that is being released. And that's also part of the reason why, even with our best antihistamines, we cannot, in all patients, block that inflammation produced by mast cells. They produce so much, they release so much in addition to histamine, that with blocking only one of the things that come out of mast cells, we can help some patients, but not all patients. So that's the rationale. That's the reason why we say, well, sometimes in some patients, we have to go one step up. It's not enough to look at what comes out of the mast cell. We have to block everything that comes out of the mast cell by stopping what activates the mast cells. And since one of the reasons why mast cells get excited in chronic spontaneous urticaria is IgE, we use anti-IgE. And now also other blockers of other ways of activating mast cells.
Okay, so is that where some of the new drugs coming
Yes,
out? Okay.
Yes, this is where the new drugs come in. So all in all, we can produce certain neutralizers of mast cell mediators. We can produce neutralizers of mast cell activation, but there's two very exciting developments right now. We have mast cell silencers. That is
okay, so does that just kind of shut those down?
Exactly. No matter what activates the mast cells, it could be IgE, it could be something else. If we use a mast cell silencer, it basically puts mast cells to sleep, and they cannot get activated by whatever signal it is. And lirentelimab, for example, is such a drug that is currently under development. Mast cell silencing is very cool. You know what's also cool? To not have mast cells. There are no humans. Yeah, there are no humans on this. Well, there are very few. Most of them live in Berlin because we made them mast cell-less. So we have an antibody now, a protein that makes people lose their mast cells. And guess what? You cannot have urticaria without having mast cells. So we have really mast cell deficient urticaria patients, cold urticaria patients, symptomatic dermographism patients here in Berlin who no longer have the disease, or I should say the signs and symptoms, because we can make the mast cells go, but they do come back after some time, so that we have to retreat and make them go again. All I'm saying is we are looking at some very exciting new ways to teach mast cells to sit down and shut up and even go away, and at least stop making urticaria patients suffer from what comes from their activation. On top of blocking mast cell mediators, mast cell activators, we can silence them, we can deplete them. We have some really cool things coming your way.
Yeah, that sounds so. Are your mast cells not needed then for like your immunity and that kind of thing? Does that go and affect that?
We're at the beginning of everything, but the people who right now don't have mast cells, they're fine. Well, they're more than fine. They don't have any more urticaria, and they had really bad urticaria when they went into this. So we're looking at, of course, at all the things that mast cells may be good for, but so far, no, knock on wood, all good.
So you can still fight infections and everything just fine without them.
Yeah.
Wow, that's really interesting. I'm looking forward to hearing more about that. So that'll be like the next 5 years, he said.
That'll be the next 5 years, but these clinical trials are ongoing. We are offering the mast cell silencers to patients to come into the clinical trial. We have the clinical trial with the mast cell depleters, and we have many other trials with inhibitors of mast cell activation, inhibitors of mast cell mediators.
Oh, that's really exciting. So yeah, lots of progress sounds like is being made. So as far as the research too, is there more research being done about like genetics? Does that have anything to do with the treatments?
Look, the most research we do is aimed at trying to figure out why this happens. And we're pretty sure that this is not a major genetic disease. No, it doesn't run in families. We haven't found a gene yet that makes it come. So it's actually very different than allergy, where it does run in the family. No, and in chronic spontaneous urticaria, yes, it's so common that we know families where 2 or more family members are affected, but it's not more than you would expect just by simple statistics. So we think it's something that happens to the immune system, that turns the immune system towards attacking mast cells, that's the autoallergy, or attacking other proteins that will become mast cell activators. That's sort of the focus right now. And Sarah, the next big thing is to add chronic inducible urticaria to the focus on chronic spontaneous urticaria. That is cold urticaria, symptomatic dermographism, pressure urticaria, cholinergic urticaria, vibratory urticaria, angioedema. We have 9 different types of chronic inducible urticaria that are not nearly as well understood or treatable as chronic spontaneous urticaria, and they can be just as devastating. If you have solar urticaria and you can't go outside because you will break out in hives every time the sun shines on your skin, it's horrible. Everything is centered around avoiding your trigger, whether this is the sunlight and solar urticaria or the cold. We had snow today. No, snow, and we are in April. If you're a cold urticaria patient in my country, half of the year is no good for you. It's too cold out there. You can't go out there without running the risk of swelling up, of developing wheals. We have to find out why patients get this, and we have to develop treatment options for patients with chronic inducible urticaria as well. So that's where a lot of the research is focused on right now.
Okay, so a lot of people with chronic spontaneous urticaria also have the inducible urticarias. So, but those do those generally go away with treatment?
Good point. Yes, yes and no. So in many of these patients, the use of drugs, of medication for their chronic spontaneous urticaria will also stop they're chronic inducible urticaria. They really have two, or three. I know patients who have actually more than three different forms of chronic urticaria. But the main point is we need to figure out why these different forms of urticaria come into existence so that we can develop treatment options that will stop the development of signs and symptoms. And I will go one step further. Our job as urticariologists in the long run is to figure out what causes this so that we can cure it. Mm-hmm. Treating it is something different than curing it. Right. I want to cure. I want to be able to do something to patients so that they stop having the disease. I can do a lot to stop having them have symptoms, right? But right now I cannot cure, and I want to cure. I want to cure chronic inducible urticaria, and I want to be able to cure chronic spontaneous urticaria as well.
I like that. That's really good to hear. That's the goal. So I know that we're running short on time here. I have so many questions still.
We'll do it again sometime, Sarah. There's always new. There's always new things.
So with genetics, so it's interesting because like my son has urticaria and nobody else in my family does. So I thought, well, that's weird, because when I got it, I was like, nobody has hives, but he has it.
Yeah.
So it's just kind of the luck of the draw, it sounds like.
It is. It is.
From what we know.
I was involved in a big project in China, which just completed, and we looked at literally hundreds and thousands of people to figure out how common is chronic urticaria. And with this really modern approach of asking this question, 3%. 3%. That means 1 in 30 people have chronic urticaria right now in China.
Oh, and so that's higher than we heard before. Because we were always hearing like 1%.
A lot higher. And really the old studies that were performed in the US, they end up with even lower percentages than 1%. So I think we're underestimating the true prevalence. That may have something to do with the fact that it has increased over time, or that we maybe got better in detecting it and putting a name to it. Either way, it is a very common disease. And this is why it is, just by statistics, to be predicted that eventually there's going to be a second person in a family who has chronic urticaria. And of course, chronic urticaria, right? No, so what it means when someone has these wheals. And if your son or someone else in your family starts to develop them, you go, oh my goodness, I know what this is because I've seen it, I know it. That may be very different in a family where no one has had urticaria, and maybe it's acute urticaria that hits someone in the family, and people say, oh, you must have eaten something bad, and then it goes away after 3 days, and no one ever recognizes that this was acute urticaria. So I think we are going to see more and better information on how common this disease is. But I also think that working on the genes, working on inheritance in most patients with chronic urticaria will not give us the information we need to be able to cure or better treat the disease.
Okay. So I'm wondering too, my thought is that the numbers are so underestimated because so many of us were told, like it's in your head. I went for many years without an actual diagnosis, so I think that's probably a lot of that too. So it's good to hear that it's more than just, the 1% that we were hearing before. Not that I want more people to suffer, but it makes me feel a bit like, wow, I'm really not alone. It's a lot of people.
I was just going to say that. One thing is for sure, you're not alone. There's lots of urticaria patients out there, and I want for urticaria patients to develop a voice. You're not loud enough for as many as you are. You have rights. You have the right for good urticaria education in the universities. You have the right for a lot of urticaria treaters out there who know what they're doing. You have a right to be taken seriously with your disease. And so I do hope that with what you're doing and what a lot of other people are doing, you will get that voice and you will get what you need. And that includes good treatment, good understanding, good information, and a better understanding moving forward, and hopefully a cure one of those days.
Yeah, well, that's really exciting that you gave us so much good information today and so much hope. So thank you so much again. Is there somewhere where people can go for more information if they want to educate themselves about urticaria?
Sure. No, there's lots of places where you can go these days. The UCARE, Urticaria Center of Reference and Excellence Network, is now doing UCARE for You. It's a patient education and information platform with webinars and TikTok channels and whatnot. A lot of interesting and important information for you to get from that global network of centers. And of course, all of the UCARES, more than 100 in more than 40 countries, are here for you to see you if you need a true urticariologist. So go benefit from what we do at UCARE, both in terms of the information we provide, but also the treatment you can get at our centers.
That's great. Thank you so much for that information.
Thank you.
Yeah, we
Thanks for
appreciate
having
you
me,
so
Sarah.
much.
Good
Yeah.
luck. And we'll
Thank
talk
you.
again sometime.
I appreciate it so much. Take care.
You too. Bye-bye.
Bye.